right, here is Chapter 5 podcast, and this is for peripheral joint mobilizations and manipulations. All right, so what is a joint manipulation or a joint mobilization? This is a manual therapy technique, and it's used to either modulate pain or treat joint impairments that limit range of motion. We are specifically treating altered mechanics of the joint. So in this class, in exercise prescription, we're not going to perform any thrust manipulation. We call this a grade 5 manipulation. We're going to talk about grade 1s through 4. All these manipulations and mobilizations, will be taught in practice at Labapalooza. We've created videos, and I'll have those up to give you exposure to the extremity mobilizations. Do not practice these at home on each other, but watch them so that you understand the concepts. We want you to understand that if you're performing an inferior hip mobilization, that will help with hip flexion. That grades 1 and 2 help with pain control, and 3 and 4 will help with movement. We expect you to understand the big concepts. That's what we expect you to get out of this class, and we expect you to have a basic understanding of how to perform them, but this is not the class that we expect you to become skilled at performing these joint mobilizations. But we do expect you to understand where they fit in within the entire treatment concepts. So definition of terms: mobilization and manipulation. This is passive, skilled manual therapy techniques that are applied to joints. A thrust is a high velocity movement. Okay, so a mobilization is not high velocity. Self-mobilization is when a patient performs a self-directed stretch to a joint capsule. Mobilization with movement, MWM as we often call it, is concurrent application of a mobilization with an active movement by the patient. So the therapist will be performing a mobilization or putting our hands on and assisting the patient while the patient also moves. And then manipulation under anesthesia, so you may see it abbreviated as MUA, is breaking of adhesions around a joint while the patient is anesthetized. So the physician will put the patient under anesthesia and perform a joint manipulation or a mobilization to break up adhesions. Often these MUAs or manipulation under anesthesia are done after several attempts at physical therapy have failed to gain range of motion. One thing you'll hear us talk about is the difference between physiological movement and accessory movement, and I consider accessory movement an arthrokinematic movement. Physiological movement is the movements that we do voluntarily, so shoulder flexion, shoulder abduction, diagonal movements. And this is the osteokinematic movement of the bone, where accessory movements are not the normal movements that we can control. So this would be a joint distraction, or if we take the joint and move it in an inferior fashion. So I'm doing a inferior joint distraction. That's not something that my muscles can make happen. And so it's an arthrokinematic movement. You'll hear all of the faculty talk about an open pack or a loose pack position. This is a position at each joint where there's the least amount of tension on the joint capsule. So the joint is as loose as it can be. When we assess a joint, we tend to put it in that open pack or loose pack position, and every joint has a specific position that is considered its loose pack position. We do have a document on Blackboard under additional resources that lists the open pack or loose pack position. I already defined manipulation under anesthesia, and there it is again. And muscle energy. This is an active contraction of muscles around a joint that can cause a desired accessory motion. We talked a little bit about muscle energy terms when we talked about the neurophysiological movements with stretching. When we talk about basic concepts of joint motion, you need to know what the joint shape is. This should all be a review from anatomy, but knowing what the joint shape is will help you to understand how you move the joint. An ovoid joint, which is just a convex on concave or a concave on convex joint, looks like the picture in A, where a cellar or saddle joint looks more like the picture in B. Motions of the joint surface come to play with arthrokinematics. So you need to know if you are moving the convex on the concave or the concave on the convex, and that will guide how you are performing your joint mobilization. So and we'll do the top picture in picture A. So right here, this would be a concave on the bottom and convex on the top. So a convex moving on concave, if you roll, is going in one direction where the slide is going in another. Where here you have the concave moving on the convex. The roll and the slide are occurring at the same time. You also have joints where there is a spin, and so such as the humerus or the femur or the radius. Right? I did include in this slide and in slide 7 and in slide 8 some YouTube videos that you can reference that just show some different ways. If you don't have a good grasp of convex and concave and the arthrokinematics of joints, it's a concept you have to have down. I say it's a non-negotiable. This will be part of what you do from now on in this class and in MSK. So if you didn't get an understanding of it in anatomy, look through those videos, find other resources, and make sure you understand it. And this is just repeating what I said. So sliding is the opposite direction of the angular movement if the bone is moving, if the bone is moving on the surface of convex, and sliding is the same direction if the surface is concave. Right, so other accessory movements that can occur at the joint. So with compression you decrease the space between those bones. It's not often that you use compression with joint mobilization. You often want to do distraction, which I'm going to talk about in a minute. But for some patients, compression of the joint does decrease pain. Traction is a longitudinal pull along the long axis of a bone. And then distraction is separation of the joint surface. Often, or from you're probably thinking, what's the difference between traction and distraction? Well, if you look at the picture to the right there, it's a humerus, and traction along the long bone would actually be an inferior joint mobilization. So if I pull along the humerus, I am pulling at the joint in an inferior fashion, where distraction would actually be heading out in this manner. And so there is a difference between a traction along the long axis of the bone and a distraction. All right, so why would we want to do joint mobilizations? What are some of the good things that happen? Well, you can help move synovial fluid around to maintain cartilage health. When there's been prolonged immobilization, atrophy of the articular cartilage can occur because of this lack of synovial fluid movement. It does maintain the extensibility and tensile strength of the articular and periarticular cartilage. Also, sensory input is very important, especially in the lower extremity, somewhat in the upper extremity. And so continuing to have joint motion is important for that proprioceptive input. Performing joint mobilizations can help with that. And it also can help regulate muscle tone. We say motion is lotion. Motion helps to decrease pain, and it does help to decrease muscle tone. You also can use mobilizations and manipulation with pain, muscle guarding, and spasm. It does have that neurophysiological effect, so it does decrease the pain based on helping with sorry, I got interrupted, so I may repeat myself. So indications of joint mobilization, it does help with pain, muscle guarding, and spasm. the neurophysiological effects, small amplitude and oscillatory distraction movements help to stimulate mechanoreceptors in the joint. These mechanical effects do help with muscle guarding and to decrease spasm. It helps to reverse joint hypomobility, especially with the more vigorous joint play movements. So when we do more stretch type joint mobilizations, it helps with positional faults and subluxation. So if somebody is held in a abnormal positional fault, and I would think people who sit with abnormal shoulder posture and their shoulder is held in an anterior position, it will help to put that shoulder back into a more posterior position where it should be. People who have progressive limitations, so instructing them to perform appropriate range of motion exercises after you perform joint mobilization techniques will help to decrease their progressive limitations. And if somebody has functional immobility, you can perform joint mobility joint mobilization techniques so that when they are able to move, they have the availability. And I think post-op rotator cuff repairs, if you can maintain the joint mobility once they are allowed to use their arm, they have enough joint play that they can. All right, what can joint mobilizations not do? Well, you cannot change a disease process. So the person on the right has rheumatoid arthritis. You're not going to be able to change the disease process of those rheumatoid problems. You cannot change an inflammatory process. And the skills of the therapist do affect the outcome. And so depending on how skilled you are and how good you are, and practice will make you better, that is the limitation of what the patient can benefit. Who should not receive joint mobilization? Hypermobility. You would never mobilize into extension this individual's thumb. If painful hypermobility, you can do gentle, and when I say never, never was a hard term. You can do grade 1s and 2s to help decrease pain, but you would not do grade 3 and 4. And we're going to talk about the difference here. 1 and 2s are for pain control, 3 and 4 are for gaining range of motion. So you would not do joint mobilizations to gain range of motion on someone like this. Joint effusion. You would need to do the gentle techniques to get rid of swelling, such as this, and not aggressive joint mobilization techniques. And for inflammation, somebody with a highly inflamed foot like that would not need joint mobilization techniques. And these individuals require special precautions if you're determining whether to do joint mobilizations. Individuals who have malignancy, bone disease that's detectable on a radiograph, such as osteoporosis and osteopenia, an unhealed fracture. So with an unhealed fracture, you may want to do above or below the fracture site, but you would never want to do anywhere near it. So, say if their distal radius was unhealed, possibly their elbow could be mobilized. I still would, I would have to be highly cautious of that. Hypermobility and associated joints. So if I know somebody is hypermobile throughout, I would be very cautious in doing joint mobilizations. An individual who has had a total joint replacement, you need to ensure that they're very stable. Somebody who's had a hip replacement, we already know that the stability of hip replacements is not the greatest. I'm not sure I would do a joint mobilization on an individual who's had a hip replacement. Newly formed or weakened connective tissue. We talked earlier today about how long it takes for connective tissue to start to heal. We'll talk more about that in, I think Matt said, chapter 10, but you need to let the tissue heal before you begin to aggressively stretch it. In elderly individuals, they have weakened connective tissue, decreased circulation. You need to have gentle techniques and to ensure their tolerance to joint mobilization. All right, so you're thinking of applying joint mobilization to a patient. So what are you going to do? So during your examination, you need to assess the quality of their pain. When you're assessing their joint mobilization, or joint mobility, I should say, you want to determine whether they start to feel pain before you notice a limitation. So let's say you're assessing their shoulder joint mobility and you start to move their shoulder, but they have pain before you notice a limitation. Or maybe you get to their joint capsule and then you notice pain. Or maybe you start to stretch them and they notice pain. No, you would expect some pain, and by I say pain, you would expect what I would call a stretch when you push past their limitation. But if they're having pain before then, they're not going to be able to tolerate a grade 3 or 4, or they're not going to be able to tolerate aggressive mobilizations. Notice if they have capsular restriction. So there are things called capsular patterns that are present. Notice their capsular end feel. So is it an empty end feel, which would be that pain before limitation? Is it a very hard end feel? Are you feeling like it's bony? So notice what you should feel, which is a firm capsular end feel with overpressure. And notice what kind of joint play they have. Now, a lot of these joint plays are things that you're going to have to get used to feeling. I expect, I know how much shoulder joint play to expect because I've felt a lot of shoulder joints over the years. You guys don't know that yet, but over the next 2 years, you're going to get plenty of opportunities to feel shoulder joints and hip joints and knee joints and elbows and wrists and all of that. And so being able to assess a joint and determine if that's normal movement or not. Also to be able to assess if it's too much movement, if this joint is subluxed or dislocated. And those are all things you need to be able to assess during your examination. Right, when you're treating a patient, you have to document the rate of the force, location of the available movement, the direction and target of your force, the structural movement, and the patient position. So this is how I would document this. Patient received grade 1 glenohumeral posterior joint mobilization with oscillation to increase shoulder flexion with patient supine, no pain noted with mobilization. Now, I'm probably completely confusing you guys and saying, why is a posterior joint mobilization increasing shoulder flexion? That's a whole nother story, and we will talk about that when we get into the shoulder. That has a lot more to do with posture than it does actual arthrokinematics. That is the one time that the majority of the patients, it goes against the convex concave rule. So sorry, I just realized I probably threw you a curveball there and confused all of you. But that is a good way to document. Okay, so we're going to talk about the different grades of non-thrust oscillation. A grade 5 is a thrust. We're not going to do that in this class. Grade 1 is a small amplitude at the beginning of the range. It is for pain inhibition and fluid movement. And I'm going to skip to the next slide and show you what that means. So if this is the beginning of the patient's range of motion and this is where the patient's tissue resistance is and where you start to feel a stretch, a grade 1 is just here. You're not stretching them at all, okay? So it is small amplitude here at the beginning of their range. A grade 2 is a larger amplitude within that range. It is also for pain inhibition and fluid movement. It's just a progression of grade 1. So it is a little bit more than a 1. You're still not getting to tissue resistance. Okay, so it's a larger amplitude within their range. A grade 3 is a large amplitude up to the limit of the resistance. And this is a stretching. So larger amplitude into a stretch. Integrate 4 is a small amplitude at the limit into resistance and is also a stretch. So you are here doing smaller amplitude into the stretch. So would you ever do a sustained? Absolutely. So when managing pain, you can either do a grade 1 or 2 oscillation or a sustained joint distraction to help with the patient's pain. This would be dictated by the intensity and frequency of the joint play, the patient's response. Distraction is very comfortable to most patients. So are grade 1 and 2 techniques. Sustained, meaning you don't oscillate, you put a patient into a position and hold, tend to be very comfortable for patients who are painful. I do both. And a lot of times, if a patient's painful, I do what feels the most comfortable for that patient. If I'm trying to get to where I can do a grade 3 or 4, I need that patient relaxed as best I can. And I will do what I notice is relaxing that patient the most. There's some evidence to show that if the joint play loss has been present for a while, then sustained positions or the sustained joint play techniques are best because you get that creep and plastic deformation of the connective tissue. Again, if you're stretching a patient, they may be a little more comfortable if you put them to that end of their range and hold them there. If you're trying to maintain it, though, you can use either oscillating or sustained techniques. So by sustained, I mean getting it to that range and just holding it. And I'm going to talk about thrust manipulation, but again, we're not going to be doing this in exercise prescription. These are techniques we're going to learn in musculoskeletal, but these are small amplitude, high velocity. This is what you think of when you think of a manipulation. This joint is moved to the limit of their range. You remove all their slack and then do a high velocity movement. You do this to snap adhesions and reposition joint surfaces. All right, so when you are doing passive joint techniques or joint mobilizations, here are some things to consider. You want the patient as relaxed as possible. In this picture, they show stabilizing the patient with a belt. I don't tend to do that. I think they're doing it to help hold the scapula in place. I find with patients who have shoulder problems, the weight of their body tends to hold the scapula in place enough. I've not had to stabilize patients with a belt, but if you remember to when Dr. Hodges was mobilized or doing contract relax with her son, he was sliding all over the place. But again, that was a wood floor and a kid on the ground. We don't typically treat like that. And so if you need to stabilize, you can. I often, if I feel that a patient is going to move, I'm not shy to ask one of my coworkers to assist me. And so you can stabilize using belts if you need to, but you can also ask for the assistance of a coworker or use a table or some other piece of equipment or the patient's body weight to help stabilize. Examine the joint play to see the restrictions. So move the patient to determine what is tight, assess their pain. You initially perform the assessment in that loose packed position or in the least painful position if you have to. It's best to stabilize one side of the joint. You typically stabilize the proximal end just because it's the easiest end to stabilize. It would be hard to stabilize distally and move proximally. When you're applying passive joint techniques, the direction and target of your treatment force, you need to apply the direction as close as possible to the joint surface. I'm going to go back to this picture. If the therapist was applying movement up here, you would get more osteokinematic movement instead of arthrokinematic movement. We want the force at the shoulder or right at the joint. So this is an example of an anterior shoulder mobilization, and you see her arm or her hand is right at that shoulder joint. The larger the contact surface, the more comfortable it is. Again, you see as much of her hand. She's got her thumb, her web, and her entire index finger on that patient. If you are using just one part of your finger, it's going to be uncomfortable for the patient. You want the treatment plane perpendicular to the axis of rotation, and so she is pushing directly up, which is the axis that she wants to be doing. Distraction techniques are applied perpendicular to the treatment plane. So if she's distracting, she would be pulling directly out, which may be what she's doing with this hand. And gliding techniques are applied parallel to the treatment plane. And so she is pushing directly up. Now, some things I want you to consider. If this was, let's say this is the femur and this is the tibia. Okay. If I want to, let's say this is anterior and this is posterior. If I want to do a joint mobilization and I want to improve, let's say I want to do a anterior tibial mobilization. I can take the tibia and move it anteriorly. But I want you to realize that moving the tibia anteriorly is the same thing as moving the femur posteriorly. Because if I wanted to do a anterior femur mobilization, I can take the femur and move it anteriorly, which would move this femur up towards the top of the tibia. Or I could take the tibia and move it down and that would do the same thing arthrokinematically here at the knee and move it posteriorly here. So some joints, whether you're moving the proximal end or the distal end, you have to think, what at the knee do I want to happen? And so an anterior femur or a posterior tibia will be the same mobilization at the knee and will create the same movement at the knee. So you just have to think of what's going on at the joint to be able to create that movement. Some other things regarding performing joint mobilizations. Always warm up the tissue prior to stretching. You can do this actively. You can do it with hot packs. I'm a fan of an active warm-up. Muscle relaxation are for grade 1, 2, and they may inhibit muscle guarding. And you can alternate these between grades 1 and 2 and then grades 3 and 4. Patients may start guarding with grades 3 and 4 and then relax some after you perform some 1s and 2s. You can glide into the painless direction first if going into the restricted direction is too painful. You can glide into that painless direction to get them relaxed and then move into the painful direction if you need to. Anytime you're doing grade 3s and 4s, take up the slack, so to speak. So don't just rip it to the end of the motion. Take up the slack, get to the end of the motion, and then start doing the oscillations. And that'll make the patient way more comfortable and less fearful. All right, please let me know if you have any questions.